Okay, so let me introduce our next speaker. So our next speaker is Dr. Ezhilan Naganathan. And Dr. Naganathan is currently a member of the Legislative Assembly in the Government of Tamil Nadu and a member of the COVID-19 Legislators Advisory Committee. He has been a strong critic of exclusionary policies such as NEET, NEP, and NRC, and majoritarian policies. He has actively taken part in debates and interviews in regional and national television in India on topics surrounding social justice, state government policies on inclusion and education. Dr. Naganathan, we welcome you.
Good evening, friends. First, I'd like to thank Dravidian Professional Forum for giving this wonderful opportunity to talk about COVID and healthcare policies. So, as I was briefed about this particular discussion by Panneerselvam sir, he said that what does Tamil Nadu has to offer in COVID management to the other parts of the world? In those perspectives, we're going to discuss areas regarding COVID management. As a treating physician, thanks to Harvinder sir to give me an opportunity to treat innumerable number of COVID cases right from wave 1, which was taking care in a ward as well as in SARI ward and intensive care till now, where we have dealt about 3 waves: first wave, the second wave, and the third wave too. As a doctor's perspective, I'll enumerate few points on COVID approach as an individual treating physician. Second, as a legislative member, how good governance plays a significant role in managing a COVID pandemic will be the second part of my speech. And the third is, what are the do's and don'ts? So with this framework, I'll begin my talk as a treating physician on the first base. See, during this COVID, as we know that COVID is a viral infection and has caused a world pandemic. It followed the same classical flu pattern so far, right? If you were able to go back to your history books and find out about the history of virology about Spanish flu, it had a similar pattern. See, those days where we didn't have virology, we didn't have RT-PCRs to document any infection, just symptomatic and not proper data registry system across the globe. It followed the same wave for the first wave, which we were completely clueless how to manage about the first wave. Prior experience of flu viruses or H1N1 helped us to manage, and we are able to find out the do's and don'ts because by trial and error method, because studies were not there much, data were not very much. And second wave where we had prior was a peak with increased mortality, which is followed the same Spanish flu. And the pandemic becomes an endemic in various segments or various parts of the world after the third wave. So hopefully, if COVID follows a typical follows a typical flu pattern, unless for any mutating viruses or mutant variants are coming up to produce more trouble for us, I would expect that it would be an endemic, and we will learn to live with COVID-19. So coming to the first wave, as a treating physician, when few cases come up, our treatment center, Kabriya, where we had a discussion that who are the doctors who are willing to manage COVID cases. So we were completely clueless. Stated cases started slowly coming up with respiratory distress. A learning curve is where are the cases where we have to admit to the ward, or we have to admit the cases into the SARI ward, or which are the cases we need intensive care, what type of mode of, because hypoxia and type 1 respiratory failure was typical, and what was the diagnosis, what are the symptomatology, how do we combine symptomatology along with an imaging technique with plus or minus RT-PCR tests, which were in the initial stages of detection of COVID alpha wave. Then with the constellation of symptoms, who are the high risk category, who are normal, who would you advise to be asymptomatic cases, who are asymptomatic carriers basically, and who are the high risk cases where we have to admit and monitor whether they'll go for severity. And if the patient comes with severity, what type of oxygen delivery, via through prongs, via through the mask, or whether we have to give high flow oxygen, or we have to give an high pressure non-invasive ventilation or not. So lot of vague unanswered questions were there during the wave 1. So when we started dealing with cases over a period of time, we started learning about COVID management step by step in a very, very, very crude way. So COVID tested us with, especially the nature always tests us, with all this modern science and technology. And we were always arrogant about ourselves as human beings, at Homo sapiens. But this virus, which is more advantage and survival advantages, taught us very crude lessons. So we were treating more mechanically viral diseases, because we didn't have any particular specific antiviral drug. A lot of experimental therapies were there, and a lot of wrong guidances. If you go to the wave 1 and if you see the ICMR guidelines, you would really think, okay, what an Indian Council of Medical Research giving such guidelines. So that amount of shocking revelations will be there, where people introduce some type of treatment protocols and then they withdrew the treatment protocols. A lot of misuse of medications were happening during the alpha wave 1. But end of the day, when wave 1 came in, see, if you were to understand dealing with COVID in the Indian perspective, you should know the Indian way of system here. We have a quasi-federal system, we had a union government, and we have a union of states. See, we have to understand that in this union of states, we have a diversified healthcare systems across the states in this country, right? If you're able to take, as to express more elaborately or frankly in this Dravidian professional forum, Tamil Nadu was showing the way to the rest of India. See, Tamil Nadu and Kerala, because those are the states who had a very strong public health system services which were there. It's a cumulative public health system over the period of many decades, right? So we had a strong public health system driven by a lot of social intervention. So whenever any health or education policy changes to percolate down under, it should be preceded by a social intervention. Social intervention means the social intervention would nullify the various hierarchy system in the society, and any intervention in health or education, if you're going to introduce, it will percolate down the ladder only if that predates, if a social reformation system predates an health or education intervention. So that's the lesson from Kerala and Tamil Nadu. So with that lesson, Tamil Nadu was able to drive in a Dravidian model where more investment in social sector upliftment, and that reflected in upliftment in education scenarios as well as in health system. So for example, lower socioeconomic strata to be treated, which is a huge chunk in Indian population. For delivery of health system to a lower socioeconomic strata, we had health support system, whether doctors, nurses, as well as hospital structures, public health system from the lower socioeconomic strata. So any social intervention or social reformation system, we had treating physicians, treating nurses from the social in a government public health system. So any type of, in a situation of pandemic, the case approach or the pandemic approach, when you have a strong public health system in hand and ably supported by a private setup, where we have a very synonymous and relationship with the public-private partnership, which will elaborate over the time of my talk. So this particular approach, which is the Dravidian model of % of our health budget towards health in Tamil Nadu state budget, as well as we have nearly have a high doctor population ratio equivalent to any other European nations. If you're able to, or retainership within the state of Tamil Nadu, we had got a very good incentivized system to retain doctors. In between calls are disturbing my conversation, no issues. Then we have very strong medical college treating hospitals in each and every districts. We got ably supported district hospitals as well as primary health centers. So the care of delivery was at all levels, right? So with the system, and a pandemic turns in, And we have many cumulative data accumulation or coordination between various segments of the society, where we are in constant rapport relationship with learning curves from different hospital experience during pandemic, especially in Tamil Nadu. So all were put into a collective picture, and we developed an independent model. For example, if you say Tamil Nadu still reverse RT-PCR is a gold standard of diagnosing COVID-19. As in case of the rest of the country, we have the rapid antigen test, which shows a lot of false positives too. But in Tamil Nadu, the government took a strong policy. But for that, are we equipped? Yes, it was escalated. It was upgraded to have a very strong rapid technology to be introduced both in government sector as well as in private sector for RT-PCR technique. That for diagnosis per se, I'm talking about. Then the wave one was introduced. See, now union government started giving data in the form of districts. It failed to arrive at a consensus to have a uniform collective communication with all the states. I would say regarding travel restrictions or regarding imposing lockdown. So each state has its own way to deal with the pandemic. But this collective discussions didn't came from down under. So few experts, as you said, lockdown. In the phase one, we had a very prolonged lockdown, which is responsible for the huge rich and poor inequality which took place. We had a huge economic onslaught on lower section of the state of the society. We had huge amount of segment of people went below poverty line. We had a huge segment of the people who went for starvation. So those things happened after the lockdown. So the lessons learned during the wave one is, as a treating physician, how to manage a COVID case, one, yes, hard lessons learned, and how a government policy making can influence the entire country to such amount of impact. And if a state like Tamil Nadu, who has a cumulative strong public health system, will able to deal with it. So in spite of this strong public health system, the second segment I'll come to it is how a good governance changeover will play a major role. Previous speaker Dhanapal sir was talking about intelligent finance minister. I was quite shocked. Then he came of Tamil Nadu rather than India. I was quite shocked in the first segment. The second segment is true. So we have a change of governance which took place in somewhere during the second wave. See, as a legislative constituency, as a people representative, we took over a changeover from a previous regimen, from a new regimen with effective leadership, which came around, say, around May mid. So the wave one in Tamil Nadu, we had around a peak was around 11,000 cases, and average 7-day average was around 5,800. But peak two, which carries the Delta variant or Delta plus, we had a peak case of 35,000 cases flocking per day, and weekly average was around 34,000. At the time, we had a government changeover. So when the government changeover took place, we had a very good leadership from our chief minister, who immediately jumped into action. What he did is he diverted the entire strength of the entire government machinery of Tamil Nadu in order to tackle the Delta variant. Because in Delta variant, 3 weeks before the peaking, the Tamil Nadu oxygen requirement was just 220 metric ton. It scaled up to requirement around 600 to 800 metric ton. The oxygen requiring beds, both in public and private, were around, say, 500 to 600. Then it was expanded to 1,000 and to 5,000. Now we had a challenge of, we said that the typical scenario of people rushing for oxygen, people rushing for intensive care beds, that amount of a tall peak with increased mortality came into. But this time, because the vaccination was very, very primordial at that point of time. So during May time, the vaccination for first dose was literally less than, say, 8.34%, and second dose was little less than 2%. So what has happened? What has happened when committed leadership comes into play? Our chief minister took a concept, something called collective governance. So what do you mean by collective governance is, See, I'm a legislative member. I was in the committee of COVID-19 management protocol regarding representing party in the government. We had also had the ex-health minister in the committee. That's the beauty of it, because it was not politicized. So you want to send a clear message that we had representatives from all political parties who are people representative formed a committee. Then there was a specialist expert committee which comprises of both private doctors, private experts, as well as government doctors who had good experience in wave one. We had some international experts to guide us to have something called an international orientation to approach to COVID. So 3 groups were guiding the government to how to tackle the COVID. So the first requirement was like literally like ABC, critical care, triage concept. So how to escalate oxygen, how to escalate intensive care beds, how to incorporate private players into the government side. So government came into action that with 2 or 3 good interventions, like it called for a lot of industries. It called for the industrial units to set up oxygen. Within a span of week, the 220 metric ton oxygen requirement, which was necessary, was escalated. The Tamil Nadu oxygen reserves went to 800 metric ton. Within a span of, say, I would say 2 weeks, fortnightly, the scale up was made. Then talking to private as well as government hospital, putting up SARI wards and oxygen requiring wards were developed. Then there's a confusion going on for requirement of particular vital drugs. So drugs with certain management protocols had his own experience on remdesivir. Certain management protocols had his own experience on tocilizumab. Certain management protocols on requirement of basic steroids or availability of heparin. So there was something called a state centralized drug delivery system, because there was huge black market was priming up of purchase of, and brought in and regularized the supply of these essential drugs. It had a very good fine system where the hospital has to upload the patient condition and the requirement and dose, and the government will rationalize and give the drug delivery test. That played a major role during drug crisis, especially during the type of the second wave. Coming to the vaccination part, see, CM himself took up as a dramatic example to take up the vaccination dose. That played a major role, because previously Tamil Nadu government, the previous regimen, as you know, there was an incidental or coincidental death happened to a film actor after a vaccination. That created a real dampening effect on, because people in Tamil Nadu, you know, the culture and value stream of people of Tamil Nadu. See, yearly say Naradam is a part and parcel of our life. So if you have a famous actor of taking COVID vaccine, and if you and due to his underlying medical condition, he is going to expire. The people really put on blame on the vaccination due to the temporal relationship immediately. So that jinx was there. So as a legislative member, in order to, because CM has given a thing called make it as a people's movement. So that's the instruction Chief Minister gave us. So when we all the legislative members, being myself as doctor, in a legislative assembly which contains 250,000 people, we started vaccination camps street by street. So I don't want to go into the politics of vaccine procurement, how it should be decentralized, and how the central government came in after the Supreme Court intervention. That's apart. But managing a vaccination drive as a people movement, CM himself came as a dramatic example to say that, come on, my people of Tamil Nadu, I'm the Chief Minister of Tamil Nadu. I am taking up this vaccine. No much of side effects. Come on. So that gained a lot of momentum, so that we were able to vaccinate a lot of people street by street. Literally within a span of say 2 to 3 months, the vaccination coverage of first dose really escalated. The last governor's address in the month of Jan, from 6.3%, within a span of 8 months, the first dose vaccination reached around 87%. Then the second dose, which was really less than 2%, escalated nearly. It is the commitment shown, or a dramatic example shown by good governance and good leadership. And if you've got an appropriate team with a strong public health system in place, is responsible. Coming to public-private partnership. See, all the union government budgets will say about public-private partnership, right? But we have really implemented public-private partnership long time ago in Government of Tamil Nadu. Simple, you take the health insurance scheme by Kalankar. See, people who are in waiting queues for life-threatening surgeries or life-conserving surgeries in government hospitals because of lack of beds or lack of availability, government started encouraging insurance concept so that the people can get operated in private hospitals so that the waiting list comes in. It's an excellent public-private model or health system. So that CM insurance health system model was really worked out in COVID management too, where private hospitals were able to rope in to give COVID care with various reasonable amount of price slabs, because it was very, especially in COVID management. So especially managing the patients in the ward, managing the patients in the SARI ward, and managing patients in this way with a reasonable cost slab was given so that the insurance would cover each and every patient. We have transplant programs in Tamil Nadu. We have transplant programs where each transplant program amounting to 11 to 13 lakhs, which is being sponsored in the form of insurance scheme from the Government of Tamil Nadu. I won't say that amount would have spent in any part of the segment of the world. So that amount of public-private partnership played a major role in dealing with this. Now we come to the third wave segment, right? We've seen how collective governance effectively worked. We have seen how strong public health system, a state which has a good amount of social reformation movements to take place in healthcare delivery. Now we are dealing with the third wave in a much more comfortable way. See, now we are seeing cases who are vaccinated coming with very mild symptoms, more of home isolation. We have receiving cases who are vaccinated, but the severity is very minimal. Very elderly people, people with immune suppression are landing up in our intensive care. Now we know how to treat a COVID case, how to reduce the mortality of the COVID case, how to reduce the severity of a COVID case. And then we have been accommodated, apart from how about the physical distancing, hand washing, and really vaccination, even though it doesn't prevent an infection or reinfection, definitely it reduces the severity of illness. That's a strong message. Is really reached our people of Tamil Nadu to proper channels, and every doctor, especially both public and private, have strongly advocated the strong messages across. Yeah, I do accept that even we have superstitions always been a part of our life. So people superstitions about the vaccination, all the anti-vaxxers, all this WhatsApp message, all literally died out over a period of time because people are quite scientific in Tamil Nadu. People are quite rational in Tamil Nadu to understand that vaccination plays a major role. Even elderly people, uneducated people, the vaccination coverage is really effective, especially in urban and as well as rural household. Even we had public health doctors who went in various mountain tribal areas to give vaccination, especially home vaccination, village vaccination, door-to-door vaccination campaign is also on the way. So vaccination plus natural infections from first wave plus natural infection from the second wave, producing an hybrid immunity. And now we are entering into the precaution dose. All have been on the same track regarding COVID management. So here we have third wave, which is on the declining trend. We are in the descending limb of the third wave, hopefully. And naturally, this corona will become like a endemic, like any other flu or respiratory viruses. All sudden, if it doesn't have any much of variations or any of the strain variations going to take place, especially other variants which is of a significant impact on the severity of the illness. See, virology in a developing nation has to be addressed. See, virology approach in a developing nation and a virology approach in a developing nation is two completely different approach. You see, the West or the developed world, for them, documentation of each and every infection is vital, because the West have contained the infectious diseases by source reduction, by giving surmountable amount of best sanitation, better water, drinking water, better drainage system, and source reduction in the form of society cleanliness, community approach again saying it's only a community approach which reduces the infectious component. The source reduction played a major role rather than pharmacological method. See, for us in developing nation, the concepts of source reduction in the form of gross aggressive intervention in the form of proper drinking water, proper sanitation is not taking place. We have taken a pharmacological approach to treat, that is treating cases rather than preventive aspects. So developing nations have to learn lessons from the West, how they have reduced infection in the form of source reduction rather than pharmacology approach. See, simple, you take our approach to tuberculosis. Our approach is tuberculosis, not source reduction, not better nutrition, not better environment, not better air, but our approach is DOTS, giving direct observant drug therapy, right? So that approach is still persisting. Now, COVID has taught us that lesson, especially for developing nations, that virology should be dealt in the form of environmental awareness, the form of personal community cleanliness, and the form of source reduction. Second, see, the data or the numbers, the approach is different here. You see, we are more in developing nations. Our approach is how many number of cases are getting admitted in the hospital, how many number of cases are requiring oxygen support, how many number of cases are requiring ventilator support. So that data is more relevant rather than the clock taking number of cases, which causes undue panic reaction among the people's mind. So that psychological impact is very much here, because to understand the essence of democracy, we have a long way to go. To understand a viral pandemic for our people, it's a long way to go. So our data system should be strengthened for our research purposes, but for delivery or information, we should restrict our case number of cases to the admitted in the hospital, number of cases requiring oxygen, or number of cases requiring ventilator care when compared to the West, which documents each and every cases every day. That's one approach. Third, R&D. See, research and development plays a major role. See, we are very far more behind in research and development in health care allocation. See, we have a union finance minister who's clubbing health along with water and sanitation and giving a percentage of GDP, right? But what is in health allocation and R&D in health budget? Very, very minuscule. So we have primitive approaches in ICMR, outdated approaches in ICMR, right? Tell me, we have experience in Tamil Nadu or in India. We have such amount of varied caseloads of experience, right? Number of cases, people with severity, mortality, people with hybrid immunity, people with cross vaccination. Tell me how many research papers came out. Tell me how many research was funded with a lot of data here. Why can't we conduct? Why we are not able to conduct simple remdesivir trial like the pine tree trial recently in NEGM? Why can't we conduct a multi-central trial in India? Why didn't ICMR literally gives a pathway so that we for funding, so that we do a multi-sectoral study or a multi-center study in various centers across the country? Why? Where's the leadership of R&D here? So we are research, investment in research and development, we are really far behind, where we have to evolve our strong health systems so that we contribute in R&D, so that we're able to deal these type of pandemics in much more better way. And at the last, see, whenever we are going to, whether it's a man-made lab virus, or whether we have breached the environmental habitat of zoonotic diseases to get this virus, it is going to happen in future years to come. So the environmental consciousness of us should be ascertained. So especially in Tamil Nadu, I think Tamil Nadu should lead the way to show to the other segments of this country or this subcontinent that we have got a strong robust health system, more investment on preventive approaches, and more investment in R&D, as well as with environmental consciousness, we'll able to deal the pandemic in a much more better way. Thank you.
Thank you so much. Thank you so much, Dr. Naganathan. That was very inspirational. And I think you really showed how Tamil Nadu is leading the world here through social intervention, through public health intervention, and through novel technology and, retaining healthcare workers. And I think we can see how much of effort you put into this as well and contributed. So thank you very much.